Good morning, and today we're going to be talking about the composite tray setup and the actual composite procedure. And so first we're going to greet our patient in. We're going to have them take a seat, and then we're going to go over with them their health history, any health concerns with the anesthetic, or if they're taking new medication, or if there's old medication that they're not taking no more that we can remove from their file. We're gonna go ahead and explain the procedure to the patient, and we're gonna answer any questions or concerns that they might have. And if everything's good with them, if they have an up-to-date x-ray, then we can go ahead and have them sign a consent form. And then after the consent form is signed, we can go ahead and start setting up the procedure for the doctor. And so we're gonna set up our basic setup, which is our mouth mirror, our explorer, and then our cotton forceps. So the mouth mirror is for like indirect vision and indirect lighting. Our explorer is used to examine like teeth and like the decay and caries people have in their teeth. And then our cotton pliers is used to like grasp and transfer like cotton gauze and cotton rolls as well. And then we're going to make sure we have our basic hoses for our doctor as well. So that includes our HVE, our small suction, and our air and water syringe. So this is our high volume evacuator, our saliva ejector or small suction, and that's just for saliva. If we do have a lot of debris in the mouth, we mainly use the HVE hose because it is stronger, and then the tip of it is more wider. And then also our air and water syringe. And then we're also gonna make sure we have our cotton rolls and our 2x2 gauze. And so these right here are the cotton rolls, and this is the 2x2 gauze. These are dry angles, but we usually don't use dry angles for this procedure. And then also we do have this disposable bite block, or we have just a regular bite block that the doctor can use. Yeah, that's to help the patient keep their mouth open, just in case their jaw gets too tired throughout the procedure. And then we as dental assistants can apply the topical anesthetic, but the doctor has to apply the local anesthetic. So the topical anesthetic looks like this. It is a Q-tip applicator, and it's kind of like a gel. There you go. And then the doctor will do the local anesthetic, which includes the syringe, the cartridge, and then the needle. And then while the doctor is numbing our patient, we can actually go ahead with our shade guide and pick their number for their shade. And this is what a shade guide looks like. And it's best to do it before the tooth is prepped, because normally if the doctor already prepped the tooth is wider than what it normally was. And so once we have the tooth number that best fits our patient, we're gonna write it down on a note, or we can just write it on their chart so we don't forget. Okay, next the doctor will start prepping the tooth, and the doctor will go in with the high-speed handpiece, which looks like this. And he can use this with usually with a 557 or 330. And then if there's really deep decay, the doctor will go in with a slow speed and a contra angle, and then a latch typer attached to it. So I'm going to show you what that looks like. So this is our slow speed with the contra angle, but it does not have a latch typer on it yet. Or actually, no, yeah, it does. That example does have a latch typer. And then if there is still decay in the tooth, the doctor will usually go in with a spoon excavator and just scrape out the walls and the bottom of the tooth so he can get everything out. This is what it looks like. It actually looks like a little spoon. There's two sides to it. You have this kind of carvy side, and then you have this like kind of circle flat end. And I'm pretty sure the doctor goes in with the spider to just scoop that all out. And then we're going to place, with us dental assistants can place the dental dam on the patient to isolate that main tooth, which looks like this. These are the actual like rubber dam, and then that's what the tooth will look like in when you completely put the whole rubber dam on. And then the doctor will decide if the tooth needs a Tafelmeyer, if the like interproximal spaces, the wall has to be built. But if it's just in like the middle of the tooth, like he doesn't have to build the walls, then he would just need the the rubber dam. And so here's the Tafelmeyer. And then also depends on what matrix band you use. We do have these metal ones right here, or we have a mylar clear strip that goes in front of the anterior teeth that looks like this. And like I said, those mylar strips are for the anterior teeth. And then when we're done isolating the tooth that we will be working on, we will, sorry, actually, let me go back. So if the doctor does decide to use these Tafelmeyer, you are gonna have to go in with the wooden wedges, which are these. And then depending on how many walls you're gonna work on is how many, well, there's only 2 walls. So if your doctor is working on 1 wall, he'll use 1 wedge. If 2 walls, he'll use 2 wedges. And the little sharp point right here is what the doctor will put into the tooth to hold the matrix band, to help hold the matrix band. And next, we're going to etch the tooth and cure the tooth. And so our patient is gonna need orange goggles so the cure light doesn't hurt their eyes. And this is what it looks like. They're just orange regular glasses and goggles. And then with the actual cure itself, here it goes. And this is the curing light that we will cure with. So before we cure, we're gonna put the etchant. The etchant is a phosphoric acid, which looks like this. And it usually does come like that, kind of like in a syringe type needle. And it removes the smear layers, so when we put the bonding agent and the actual composite itself, it sticks to the tooth. And so after we etch the tooth, we're gonna leave on the etchant for about 10 to 20 seconds, and the doctor will let you know when you can go ahead and rinse the tooth off, and then use the HVE or the small section to section all that extra water that's coming off of it. And next is our bonding agent and primer. These can either come in their own bottles, or sometimes they come in like a 2-in-1. They look like those. And this is obviously used to bond in the composite with the tooth. And we're going to place it in a mixing well for our doctor. And because it is light reactive, we're going to close this. And we're going to prepare this when the doctor is ready for it, not when he's not ready for it, because it will start setting. And the doctor will use an applicator brush to help apply it. And then as he applies thin layers, he's going to have you cure it. So this is the applicator brush that they might use. And then again, the curing light. And he will need you to cure it. And then we are going to cure for about 10 to 20 seconds. So when the tooth is completely cured and dried, we will start filling the tooth with composite. So there's different ways that we can do this. The first one I'm going to show you is when the doctor fills the tooth with a composite gun. And it's pretty easy. It's a little gun, looks like this. And the doctor just uses that and little by little fills the tooth a little bit, cures it, fills the tooth a little bit, cures it. And then, or they can use a flowable composite that looks like this. It's like maple syrup, and the doctor just squeezes it into the tooth. Super easy. All these actually are pretty easy. And then it is disposable, so we are supposed to dispose of them after every patient. And the next one I'm going to show you is the condensable composite, and it's pretty thicker, like Play-Doh. So that's like the tubing it comes in, and it is thick like Play-Doh. And this one we would usually put on a mixing pad that almost looks like this, and that's how we would mix it out. And the doctor will just take what he needs.